George Kovac here. This is my Bougie rant. And let's be clear up front that the Bougie is not a heat-seeking missile you just place in the mouth and all of a sudden it finds the airways. It's about the Bougie being an adjunct, to optimize laryngoscopy and intubation. There's a lot of interest recently over the past couple of years in using the Bougie routinely for all airways in the ED setting. And that relates in part to the study by Brian Driver and his group published in JAMA, where they had a high first pass success rate, 98%, when the Bougie was used routinely compared to a lower first pass success rate when a styleted endotracheal tube was used. And a lot of people came out of this saying, listen, we should all, use the Bougie routinely, and that's gonna bring magic. But I think one of the big messages from this paper is that it wasn't necessarily just the Bougie. It was about this being an airway bundle. This was a group of people that was extraordinarily experienced in airway management and in Bougie use. They were routinely using a Macintosh video laryngoscope and doing an RSI in these patients. It was part of this bundle that provided this high first pass success rate, and it wasn't all about the Bougie. So when to use the Bougie? This is a slide from 1999 from our AIM program. And the most common scenario that people would talk about would be with a grade 3 view. And with a grade 3 view, which is an epiglottis only view, you're taking advantage of that coude tip, that 30-degree anterior coude tip of the Bougie that you're tucking under the epiglottis and hopefully entering the airway. Then we're realizing that really it has value with the grade 2 views for the simple matter is that an endotracheal tube is bigger, and sometimes that obstructs your view, and you don't watch it go in as easily as you would with a Bougie that you can watch enter through the cords. And so why not use it in grade 1 views so that you are skilled in using this device in other situations that are more difficult. Grade 4 views should be very rare, and there is no role for using a Bougie in grade 4 views. There's nothing gum, elastic, or Bougie about the Bougie. Some prefer to call it a tracheal tube introducer. I think that we're entrenched with the term Bougie, and most of us are comfortable with that, and will continue to use that as a term. Let's recognize what it is, though. For the most part, most Bougies are straight in a package with that anterior 30-degree coude tip. But there are variability between Bougies. Some are not malleable, some that you cannot bend, some will not retain their bend or retain that memory. And what you're seeing up here on the right-hand side is what we call memory. In other words, if you were to bend the Bougie, it will stay in that bent position for a certain period of time before it straightens out. So you have to know and understand the materials and the way that your Bougie functions so that you can properly use it in the clinical settings that are required. I'm going to focus in on video laryngoscopy and using the Bougie, and more particularly, I'm going to talk about Macintosh video laryngoscopy. On our website, we do have videos for optimized Macintosh video laryngoscopy and optimized hyperangulated video laryngoscopy. The focus here is going to be MAC-VL and the use of the Bougie. Rich Levitin and I wrote an editorial a couple of years ago, and it was about moving away from all the device stuff and concentrating on optimizing laryngoscopy and intubation. And we framed the term EVLI, epiglotoscopy, folliculoscopy, laryngoscopy, and intubation, which is part of optimizing that process so that your Bougie and other adjuncts will be helpful. It was Rich Levitin's term to use epiglottoscopy. It means don't just go in looking for the glottis, go in looking for the flag that tells you where the hole is, right? So look for the epiglottis, and then you'll be able to find the glottic inlet relative to where the epiglottis lives. Now, folliculoscopy is a term we coined, and it's what didn't used to be something that we were talking about, you were seeing. It was more of an anatomical appreciation. But now with video laryngoscopy, you can actually see it. And what you're seeing on the left-hand side, you're seeing what's called the glossoepiglottic fold. And at the base of the vallecula, that's where your blade tip wants to be. And if I can see that reflection at the base of the vallecula of the glossoepiglottic fold, that means my blade tip isn't properly positioned. And I can lift all I want here, all the pressure I want, and it's not going to move things out of the way. Whereas if I just drop it down a couple millimeters, all of a sudden I'm able to lift that epiglottis out of the way. So that's what valleculoscopy refers to, is a good placement of your blade tip within the vallecula. Now for Macintosh laryngoscopy, it's sort of pretty simple, is that using this is the Cook modified Cormack-Lehane scoring system from grade 1 to grade 4. In general, the more you see, the better it is. The less you see, the better it is. So grade 4 view, you can't see anything. There's nothing that you can identify it's bad. Grade 1, you can see everything, and it's all good. And with Macintosh laryngoscopy, tend to correlate with intubation. So if you've got a good view, a grade 1 view, tends to be easier. If you've got a grade 4 view, it is often impossible to intubate them with a laryngoscope. I'm going to start off with the bad. The most common reason, I think, for us in emergency medicine and perhaps other settings to see a grade 4, it's not a true anatomical grade 4. It's the fact that you're adrenalized and your blade tip, you didn't do epiglottostomy, your blade tip is actually in the esophagus. You're doing esophagoscopy. And that's what's going on here. The best thing to do, I think, is pull back, and you might see something different. But if this is all you're seeing, my cynical approach to this, the only tube that should go in there is an orogastric tube. If it's a true anatomical grade 4 view, these will be impossible to intubate using conventional equipment. So with grade 3 views, they're broken up really into a 3A and a 3B view. And the question is it true or you? Again, is that truly an anatomical grade 3 or 3A or 3B? Or is it because you're not doing appropriate valleculoscopy? Are you pushing the epiglottis posteriorly to create that 3B view? So again, you have to play with your blade tip and ensure that it is a true view in this scenario. Because the problem is with a 3A view, with a 3B view, you will not be able to manage that in most circumstances with a bougie that's out of the package. Whereas a 3A view, that's what, again, classically was used with the coude tip to tuck it under the epiglottis, and you'll be successful. Now, for grade 2 views, they're further broken down in 2A and 2B. 2B just being posterior cartilages, intraretinoid notch, and then the 2A being some portion of the cords. And the question again should be, is this true view or is it you? In other words, are you lifting too early? Are you not doing appropriate valleculoscopy? But assuming it is it appropriate to use a bougie in this situation? A lot of people say, well, I can manage it. There's no problem managing this if I can see the posterior cartilages or the part of the cords. But if you look back at the driver study, this was really the major finding of this study. Grade 1s, it didn't really make a difference. Grade 3s, yes, it did, but there weren't that many grade 3s. It was really the grade 2s, because that was the bulk of their airways, that it made a big difference in using the bougie. And for the simple fact is, as I mentioned earlier, when the tube approaches the glottic inlet, it can block your view, as opposed to what you see below, where you can watch the bougie go in. We ultimately talk about 3 things to do with 2 hands on first attempt, right? So this is your difficult airway drill with Macintosh laryngoscopy. It begins with, after sniffing position, doing an additional head lift and then putting in towels. That'll often, again, improve your laryngoscopy, right? You can improve your laryngoscopy again by reaching around yourself and doing ELM if that works. And then again, next thing to do is move in and use a bougie that's ready for you to grab a hold and place. Right, so 3 things to do with 2 hands on first attempt. Do it all in less than 30 seconds. And that should be your difficult airway drill. So back to when the bougie, you can argue, are you going to use it with a grade 1 view if you want to do it from a practice point of view? Definitely think that there's a role for using it in grade 2 views. For 3A views, there's a role. I question whether there's value of using it with 3B view, and there's no role in using it in a grade 4. So that's bougie as an adjunct for optimized laryngoscopy and intubation. Let's move on to some bougie mechanics. Holding my bougie, I like a naked bougie. In other words, I don't like a tube over my bougie as I use it. And that's just my preference. I hold it proximal to the middle of the bougie so I don't ultimately have to let go. There's a lot of people who have a lot of experience with using what's either the D grip or the Kiwi grip, so they can use it solo. It's a preloaded Bougie, and it is cool to use, but there are some limitations in performing laryngoscopy and intubation with a preloaded Bougie, and you just should be aware of those. And I have a video on our YouTube channel that you can refer back to. You want to keep your tip anterior. You want to keep your tip anterior with the hope that you're going to feel tracheal clicks. And just a reminder, this is what it looks like when you do it on this is a cadaver and we're watching the Bougie go down, and that tactile sensation of it bumping along, you're going to feel. And remember that the Bougie doesn't stop at the carina like some people have mentioned. The Bougie goes into the right main stem and goes into a second generation bronchus. So if you go to hold up, that's where it's going to happen. The question is when your psychological shock index is high, in other words, your heart rate's greater than your patient's heart rate, your PSI is greater than 1, are you going to be able to feel that subtle tactile feedback of tracheal clicks? And I think that's up for debate. Avoiding difficult tube delivery. You want to continue laryngoscopy. You want to rotate the your tube over the Bougie quarter turn to the left or counterclockwise as it passes or before it passes through the cords, and you want to consider using an alternative tube. You want to continue laryngoscopy because if you don't displace tissues, the tube and the Bougie are just going to fold in the posterior pharynx, right? You don't want that. You need to displace the tissue so you can seldinger that tube over that Bougie into place. If you're running into problems at the glottic inlet, it's because the leading edge of the bevel is hitting right-sided structures. So what you want to do is pull it back and rotate left quarter turn counterclockwise, and then sink it. An alternative way, which is the preferred way that we teach now, is don't wait for that to happen. Don't wait for a cue that you've got to respond that way. Just routinely, every time you place your tube over your Bougie, preemptively do that quarter turn to the left. That will take the bevel away from the right-sided structures, and you'll be able to sink it no problem. You could use an alternative tube, such as this Parker Flex Tip tube. I'm not going to talk about that in detail, but the bevel tip is anterior, so it's not going to get caught up on right and left. I certainly use this in difficult scenarios whenever I'm doing a flexible endoscopic intubation for sure, and sometimes with a Bougie. Let's go back and talk about Macintosh laryngoscopy, because we think that they're all the same. All of these devices on Google here, the ones that have the blue check mark, are labeled as Macintosh laryngoscopes, and they're not all Macintosh laryngoscopes from a shape point of view, from a camera position point of view. Some are Mac, some are Mac Plus blades, and it's important to appreciate the fact that there are differences out there. Our initial COVID RSI protocol was routinely, you're doing your RSI and you're going to do Mac VL plus Bougie. And then we backed off from that. A lot of people were having some problems with this. And at the end of the day, I think it was the right thing is to do what you are most skilled in doing. So you can do Mac VL plus or minus Bougie, but if you're skilled in using hyperangulated video laryngoscope, then go ahead and use that as a first attempt approach. The assumption is, though, when you use a Mac VL device, is that the view that you would have in the mouth, right, is the same as the view that you're going to have on the screen. And that's not always the case. It really depends on the device that you use. The study that we did, we were looking at the CMAC and we were looking at the GlideScope Mac blade, and we were comparing what you saw in the mouth versus what you saw in the screen. Now, we've concluded there was no clinically significant difference, but I'm questioning that now in retrospect. Certainly with the Mac, with the CMAC, there wasn't any difference. In other words, when you looked in the mouth, it was the same as what you saw on the screen. Whereas with the GlideScope Mac blade, there was anywhere from a 2 to 11% difference. And at 11% difference in some cases, that might be significant. Say, for example, you've got a grade 3 view and it takes it down to now a 2B view. But what that's telling you is that Mac device is actually working as a see around the corner a little bit, right? So it's seeing around the corner. And with these Mac Plus blades that are out there that I showed in that previous slide, a lot of them do that. In other words, there's a significantly improved view on the screen compared to what you see in the mouth. So what that's telling you is that you are seeing around the corner. And when you're using a Bougie, which is straight out of the package with just a coude tip, this could be one of the reasons why your Bougie goes posterior, right? Is that it's not when you have that mismatch from what you see in the mouth to what you want to see. It's better on the screen. That means it's seeing around the corner, and that you are using now a straight device with a coude tip, and you might run into problems, right? So if that's the case, where you have this mismatch, then what you should do is use a stylated endotracheal tube that you're able to manage that without an issue. Or again, what you're going to have to do is you're going to have to modify your bougie, assuming that you have a bougie that is modifiable. So we do what's called a pillow bend, where we'll take it out, the bougie, and we'll bend it on the pillow. Or again, we do that preemptively, and that gives a bend that will hold. We've got enough memory that it will hold, so it will manage that slight anterior direction that these Mac Plus blades give. When we look at bougies, again, remember the outer package is straight. We call the pillow bend, again, just a subtle one that will help you manage most of the troubles that you have with a Mac blade. A deliberate bend is something that we can use with a hyperangulated blade, and there is a steerable tip one. The other thing that will happen when the bougie goes posterior is whenever it happens, that's happening, look back at the mouth, right? Because if you have restricted mouth opening and bigger teeth, what's happening is that you are going to be pivoting. You're pivoting the bougie on the teeth, and ultimately that will cause another pivot point. You're going to direct it posterior. So whenever you're having problems and it's going posterior, look at what's happening at the mouth. So Macintosh standard geometry VL, what's in the mouth should be what we see in the mouth, we assume is what you're going to see on the screen, whereas hyperangulated video laryngoscopy, what you see in the screen is very different from you looking in the mouth. And look in the mouth, you are going to see nothing. Right? So hyperangulated video laryngoscopy and bougie use. This is a problem. If people say you can use a bougie with hyperangulated video laryngoscope, people are going to have troubles, especially if we're talking about opening a bougie up out of a package and using it. It will fail, okay? So the only real way you can use a bougie with a hyperangulated video laryngoscope is if you were to use a deliberate bend, as I showed you before, right? And this is the way we would do a deliberate bend. And we just hold it there, and with the bougie use, this is the way it looks, afterwards. And with that, we're able to manage a hyperangulated video laryngoscope. Now, the steerable bougie, people are gaga about this. Remember, what you have to do is you have to bend it down to create that coude tip, whereas with a regular, deliberately bent bougie, you already have your coude tip. So the only advantage is it allows you to reverse that bend. We'll see what the literature shows. It is kind of cool, but I'm not sure how much additional value it provides. So at the end of the day, folks, it's not about the device. It's about the hands that use it. Bougie is in my Bougie Rant. It's an adjunct, and it's adjunct to optimize laryngoscopy and intubation. If you want more detail on bougie use, I got a part 1 and part 2 deeper dive into this. And then Scott Weingart's EMCrit did a piece based on the stuff I had done on our website on Bougie Masterclass. Thanks for your attention. Take care. Bye.